If you want any shot at trying to save that hip from having a replacement, Cayman is going to be your best bet. Otherwise, it might not even be worth it to do bone marrow concentrate. All you should really care about is, hey, can I feel better? Can I get back to doing the things I want to do? How long is that going to last?
First-line treatment should not be corticosteroids because it really shoots you in the foot and signs you up for worse outcomes long-term. This is Conversations in Regenerative Medicine, and you are in the right spot. We are exploring frontiers in PRP, BMC, and MFAT. We are really talking about cutting-edge insights and tackling controversial topics in orthobiologics and interventional medicine. And so I'm Dr. Ariana Demers. I'm board certified, fellowship trained, orthopedic surgeon, sports medicine expert, and regenerative medicine aficionado. I am an educator and trainer both in orthobiologics and ultrasound, and I have successfully moved my practice in rural California away from insurance-based care, and I focus on cash-based procedures. And I am passionate about helping doctors to incorporate orthobiologics in their practice seamlessly. Tonight, Dr. John Pitts joins me from Colorado. He went to med school at Vanderbilt, did his residency in PM&R at Emory, and then went to Colorado at Santana Schultz and did the fellowship in 2014. And he currently is the Santana Schultz Clinic Fellowship Director and has been really involved in research and development as well as post-procedural rehabilitation. And he has written the nutrition guide, Nutrition 2.0, 21st Century Guide to Nutrition and Health. And so I would just want to give you some housekeeping. Thanks for joining. This is a fireside chat style where you get to hear from internationally renowned experts in regenerative medicine. And we explore a little bit more controversial side of the topics in orthobiologics and regenerative medicine. And we can gain actionable insights on how you can implement this in your practice and take this with you and get your burning questions answered. I believe that orthobiologic treatments will be first-line treatment for musculoskeletal care in the next 5 years. Here's the deal. Successful integration in orthobiologics is hard. I want a successful orthobiologic practice, and we know orthobiologic is the best treatment for our patients, but how to be successful may be a different animal altogether. Maybe you've tried some things and you say, well, I don't know the science, or I am not familiar with the techniques, or I'm anxious about cash-based business or marketing or sales. Maybe you thought, I'm just not good at business. And, it's not our fault. We didn't learn this in school. And, maybe some of us are struggling on how to be successful and capitalize on this $4 billion orthobiologic market. And so if you're thinking we deserve more, or why is this so hard, then you're not alone. Don't miss out. Please subscribe to our newsletter now to stay ahead of the world of orthobiologics. You can find the link below. Additionally, if you're ready to start this journey with me in my orthobiologics masterclass, come join us. So the question is how to win. While we are talking about the science today, we also need to actually consider how we talk about this to our patients so we all win. And so we need a system. Now, I'm not going to go over all this today, but we are going to get you a little bit further down the road on this journey to be wildly successful in your orthobiologic practice. And you need a system. So we're going to start with some orthobiologic knowledge. And so I'm going to get started with my interview with Dr. John Pitts, who is a preeminent orthobiologic physician. So let's get down to business with Dr. John Pitts. John, if you can just give me the 50,000 foot view of who you are, what you do, and why you are the expert in the room today.
I hesitate to call myself an expert, but I'm John Pitts. I'm PM&R doctor, trained at Vanderbilt for Medical School, Emory residency in PM&R. Then I came out to Colorado with the Centennial Schultz Clinic to do their interventional orthobiologics and regenerative medicine fellowship. And since that time, I've been the fellowship director and working there. So doing exclusively, orthobiologics, regenerative medicine for the past 12, going on 13 years now. So this is what I do all day, every day. And so part of my practice is every day evaluating musculoskeletal problems, head to toe, spine, peripheral joints, and utilizing prolotherapy, PRP, bone marrow contract, micronized adipose tissue. And I have the fortunate privilege of going down to Grand Cayman where we can do autologous culture expanded MSCs. So I've been doing that for 11 years.
And the question that I have is, are cultured MSCs really that much better? And if they are, how do I get my hands on some? How do I get those for my patients, right? And so really I want to know, what your opinion is of when this really is what is required.
Gotcha. And so just for clarification, I want to specifically clarify, we do autologous. So coming from you back to you, culture expanded bone marrow cells. That's where I have the most experience. You can also get autologous from adipose tissue. You can also do allogeneic cells from donor adults or from, placental type tissues as well. So I have the most experience with autologous bone marrow culture cells. And so depending on the issues you have, this is how I think about when I'm explaining, what would you do bone marrow versus culture cells? That's really the comparison because you're comparing two different stem cell treatments. So here in the US, I'm doing bone marrow concentrate for moderate to severe arthritis, partial tendon tears, etc. Now, say you have those same issues and you just want the best of the best. You can do culture cells. They work just as well or better for most indications. And there's a few indications where, based on our data, it works a lot better. So something like knee arthritis, we have really great results with bone marrow, especially with, Hernergau protocol, injecting intraosseous, a little higher volume, intra-articularly, treating ligaments and tendons. So we do really well with knees. If we compare just a single knee that's moderately severely arthritic with bone marrow versus culture, it may be a little bit better with culture, but it ain't going to be a huge difference, right? Now, say we want to do both knees though. Now we know, hey, if this person's older or postmenopausal female, the total nuclear cell counts might be a little lower. So we know a minimum dose of 400 for intra-articularly, plus you need a little bit more cells if you treat an intraosseous. So have enough cells to treat both knees that are severely arthritic with intraosseous, with bone marrow concentrate, is going to be difficult. So, one way to get around that is adding adipose to the mix. Another way to get around that is doing autologous culture expanded MSCs, where you can grow the cells out, typically to 100 to 1,000 times more MSCs. And with the culture cells, you have a pure MSC product that's resuspended in platelet lysate. You can resuspend in saline versus bone marrow concentrate is a whole mix of cells, where only a small number of those cells are MSCs. And so if you have multiple joints that require some type of stem cell treatment, Cayman's going to be a preferred place, or culture cell is going to be preferred place. You don't have to go to Cayman with us. And then if you have hip arthritis, so we should know from hip data, severe hip arthritis is really difficult to treat with anything. But if you have a severe hip arthritis, with our data, they did twice as better with cultured cells versus same-day bone marrow. So if they're a moderate hip candidate, they're going to be a fair to good candidate for both treatments. Culture cells are going to be way, way better. If they're a severe candidate, they both are going to be so-so candidates, probably a poor candidate for same-day bone marrow concentrate and a decent candidate with cultured cells. For small joints that are severely arthritic, where you can't get a large volume, like you can't put much bone marrow in a DIP joint or a PIP joint that's severely arthritic. So you might get, half a cc of injectate there. You're not going to have very many MSCs in the bone marrow concentrate there, but you can get a couple million MSCs in a small amount of volume or more to put in a joint for small joint problems. So smaller joints like a hand, wrist, ankles, those things do better with cultured cells in our experience as well. And then intradiscal. So we've got the first thing Dr. Centennial did back in 2005 was intradiscal with culture expanded cells. So we got the most experience with that. And we found the best results with intradiscal treatments with culture stem cells. and it also a little bit more reliably reduces disc protrusions with cultured cells versus PRP or bone marrow concentrate. So those are my big things why I would prefer cultured cells versus bone marrow concentrate.
All right. What about tendon? We had a presentation 2 years ago at IOF, Dr. Solar, showing really significant improvement and or healing, like perfect healing with culture expanded versus what we know from, bone marrow or even adipose or PRP. Is that some consideration? Is that not in your first line recommendation?
Yeah, I mean, both bone marrow concentrate and culture cells, I think, works for, severe tendinopathy or partial tendon tears that aren't completely retracted. So I think both of those are reasonable options. I don't see enough data or any comparison, or even in my personal experience to say, oh, culture cells for just a single tendon that needs to be treated is way better than the same day bone marrow concentrate. It may be, but I don't have any evidence or even anecdotal evidence to kind of back that up. What I do see is that they do just as well with culture cells. And, maybe the flare up is a little bit less the first few days or a little shorter lived, just because, again, you're not getting the hodgepodge of cells with cultured cells. But I can't say from our experience that is a clear winner there. I think they both work well. And it's more like, hey, if I'm already getting culture cells, I'm going to get them put in through a tendon as well. And then I've had a few patients, mostly our self-doctors, who we self-treat ourselves, but we don't follow any of our rehab protocols. So we just kind of winging it. Sometimes, with that, we're not doing all the other things we're supposed to. And the culture cells might do a little better for like a patella or Achilles tendon issue versus a same day bone marrow if you don't do your PT and other things.
So for those non-compliant patients, maybe cultured cells is a little bit better.
Yes.
Okay, good to know. Awesome. So this whole business about culture expanded. So right now, this, there's an FDA issue with this. And so one of the questions is, at what point does manipulating a patient's bone marrow transition from a medical procedure to a drug development, right? And right now, I think the FDA is kind of in transition. And so how do you consider, where do you think this is at regarding coming back to the States to have cultured cells in the States? Because right now we don't have, outside of INDs or FDA trials, we don't have access to those things. Where do you think we are at currently with that?
Yeah, so my current understanding, and I'm not a regulatory expert,
Of course.
Since Dr. Centeno was the first one to do cultured cells in 2005, he had an IND and ran a small study showing some safety and efficacy. So then started treating patients. A couple years into that, the FDA came along and said, hey, that's like making a drug. You require drug approval. That's outside of kind of 361 regulations, whereas homologous use and minimally manipulated falls under, 351 regulations where you require clinical trials, IND. So we actually sued the FDA, lost. And so as far as I know, nothing's changed in that regard, whereas culturing cells is considered more than minimal manipulation, and that requires full IND and drug trials to be performed here in the US. And so as far as I know, that's still the same thing. We've seen a couple of companies try to get some drug trials off the wave with these, but I think it's more of a funding issue because it's hard. No small clinic can afford hundreds of $millions in 10 years to run drug trials, and no large pharmaceutical company is willing to invest that because it's not a drug that you can patent and generally return billions to you. So I think it's a little bit in limbo. So obviously we got new administration. There's some things that seems like they may be more favorable towards regenerative medicine in general. But as far as I know, nothing's really changed so far as those guidelines. So I don't think it's safe from an FDA regulatory legal standpoint to start doing any cultured cells at this point right now.
Great. Well, we still have more questions. So you're not quite off the hook yet. So with the potential therapeutic gain of the culture expanded cells, does this outweigh those ethical concerns? Meaning, do you think from an ethical standpoint, are we in a little bit of a conundrum because we know that this may be a better option than what we have available in the States. How do you deal with that from an ethical standpoint in your clinic when you know you're like, well, if you come to Cayman, but I mean, it's the same kind of ethical issue is like, well, PRP and BMC aren't covered by insurance, but it's better than cortisone. Like, how do you kind of work through that and maybe talk to the patient, but also, as a clinician from an ethical standpoint and a parity standpoint, how do we kind of address that issue? Because for all we know, like you do have to have cash in the bank to fly down to Cayman and pay for it. And there's some people that would say, oh, well, you only are providing care to the rich. How do you rectify that? And I don't really know the answer. So I'm asking for.
Well, I don't think any of us know the answer, but just kind of what I do. So, one is no ethical consideration as far as the cells themselves. So these aren't like aborted fetuses or embryonic cells, which nobody uses. So there's no ethical considerations from that standpoint. But just in the field of regenerative medicine in general, a lot of times since these procedures are out of pocket, it kind of lends yourself to only being available to those who can afford it or willing to pay for it, basically. And so, my job, I feel, this is my personal take, my job as a physician in this area, like I want to be a pioneer, I want to be on the cutting edge. So I'm okay offering these therapies because I believe that they're helpful. The onus is on us to prove that they're helpful. And so I'm involved in doing a lot of clinical research and teaching and educating. So I feel good about that. And then when it comes to patients, like, hey, my job is to educate that patient on all the options, the pluses and minuses. And so when I talk to patients who think they could be a candidate for cultured cells, I'll let them know. So they have one knee that's severely arthritic, and they ask me about a clinic in Mexico that I have no idea about what they're doing. We can have good results with same-day bone marrow concentrate here. If you want the best of the best, culture stem cells can be that best of the best. You can also store stem cells for the future. But the downsides of that, hey, it costs a lot more. You got to make a couple of trips out the country for that. So those are the pluses and minuses. And so I always explain that to the patient, whether, hey, is it something they really need? Like I really recommend, like, hey, you got severe hip. If you want any shot at trying to save that hip from having a replacement, Cayman's going to be your best bet. Otherwise, it might not even be worth it to do bone marrow concentrate, just have a hip replacement. They work well. So the conversation depends on what's going on with that patient and always just trying to educate them, give them all the pluses and minuses. I don't oversell anything. I try not to sell anything at all. I just say, hey, this is what I recommend. These are the pluses and minuses of this. And when it's something where it's a gray zone, I say, hey, these are the options. This is the pluses and minuses. I include cost and logistics as part of one of the minuses or pluses and explain that to the patient so they can make an informed decision. So I feel good that I'm not just trying to sell people on some hopes and dreams. I'm trying to give them an honest assessment of what's going on. And if anything, I try to downplay benefits more so than overplay them.
Yeah, yeah. And, I think the flip side of that ethical dilemma, is it really ethical to withhold beneficial care just because of insurance coverage? And I would argue it's actually unethical to withhold or not disclose options that aren't covered, right?
Yeah, generally nowadays, like if a person has a high deductible plan, these treatments aren't that much different than if they were getting traditional medical care that's covered by insurance. So for some people, this is not even that much more expensive than what they would pay for. And then not every single patient we have doing cultured cells is rich or just has money to spend. Like, some patients are taking out second mortgages or they're just using some savings or, they're everyday people and they just want to invest in their health. And so they don't spend money elsewhere on jewelry. They'll spend it on taking care of themselves. They know their health is the most important thing. And so, it's not exclusively for the richest, for those who want to be on the cutting edge, want to avoid surgery, want some innovative therapies that can help them heal and kind of believe in that pathway.
Awesome. Yeah, it's good to remember that our current medical insurance situation, like if I come in under their deductible, I'm actually saving them money. I'm like, all right, you got a $10,000 deductible? Great. I'm going to save you money today.
Absolutely.
All right. Well, we still have more questions, John, and I really appreciate your time. So the question is, are we overpromising, and I know you just talked about, so maybe talk a little bit about what can we do? Are we actually able to regrow cartilage? Are we actually able to heal tendon completely? What do you think there's an overpromising part? Or, we talk about, is this actually the next step in evolution of autologous therapy?
Yeah, so it's a great question. So, one, just getting down to the science of biology, there's a lot that's unknown about how mesenchymal stem cell therapy works. I think some things that we clearly at least know at fundamentally is that, hey, it's pretty clear evidence that mesenchymal stem cells or medicinal signal cells, whatever you want to say, reduce inflammation, have some anti-catabolic effects, immune modulating effects, and some chondroprotective effects. So have I seen patients regrow cartilage with cultured cells? Yes. Is that the norm? Is that something I tell patients? Is that what to expect? Absolutely not. So our expectations are we're able to improve with arthritis, we're able to improve the joint environment to reduce the catabolic effects of the joint, reduce inflammation, probably have some cartilage repair or some protective effects. If we treat the bone, we can have some subchondral bone improvements there. If we treat the ligaments, we can get improvements in stability. All of that should equate to the patient feeling better, having more function, which should be the most important thing. And that lasts in maybe 5 to 15 years at a time. So that's what I can honestly tell people about arthritis based on the data. For tendons and ligaments, we can heal tendons and ligaments. That little legitimate thing where I don't say, oh yeah, we're gonna 100% heal your tendon and ligament. But yeah, you can repair tendons and ligaments so that they're either normal or close to it. I usually, again, undersell it. Hey, we can get that ligament probably 80 to 90% of normal, or so it's functional like normal. But those are things you can actually heal. Arthritis is no cure for. You can't cure spinal problems, degenerative disc disease. We can fix angular tears. We can reduce some protrusions. We can't regrow your new disc. We can't restore your disc height. We can't remove osteophytes. So I'm very clear because all these things are mechanistic. As a patient, all you should really care about is, hey, can I feel better? Can I get back to doing the things I want to do? How long is that going to last? I can tell patients that very easily from the research. What I can't tell patients is that, hey, we're going to regrow your new body, a new joint. Those things are just untrue. So then we just have to explain, hey, mechanistically, this is how it works to achieve those goals. It's not what you think. So there's just a lot of educating folks in that domain. So again, I try not to overpromise. I just try to explain the science at a basic level for patients. And when we run out of time, you can't do that. Just try to refer them to some resources they can read a little bit more on their own as well.
Don't miss out. Please subscribe to our newsletter now to stay ahead of the world of orthobiologics. You can find the link below. Additionally,
if you're ready to start this journey with me in my Orthobiologics Masterclass, come join us. Awesome. That's really helpful. And I love that. Oh, you think no, this is not what it is. It's all about symptom management and modification. I wanted to just take that time because I do know of even PRP. Dr. Jane Fitzpatrick just came out with her 5-year data for gluteus medius tendinopathy and partial tendon tears, and 50% of those healed with straight PRP. And so for that, number one, awesome data to have. And then number two, and I think this part really kind of got underplayed, but for me made a huge difference, is the ones that didn't heal or did not as well all had exposure to corticosteroids.
Interesting. Yeah, I believe that. Yeah.
And so I use this as a platform to please, first-line treatment should not be corticosteroids because it really shoots you in the foot and signs you up for worse outcomes long-term.
Yeah, and with these orthobiologic treatments, I explain it's like you kind of trying to go to Vegas and count cards and stack the deck in your favor. So, very reliably, PRP can help with tendinopathies.
Yeah.
When it comes to partial tendon tears, if you're younger and there's small tears, PRP probably can heal those up. If you're older and there's some larger tears, hey, maybe PRP can do it, but it's not as reliable. You might need bone marrow concentrate or stem cells when you get it a little older or when you get to larger tears. And so I just kind of explain things in that manner. It's like, hey, yeah, you get severe arthritis. Could PRP help? It's possible, but it's a lower likelihood to help. and it's lower likelihood to last as long compared to a stem cell treatment there. You got mild arthritis, PRP's got great data. I don't even think you need to go to bone marrow or stem cells to do that because you got really high chances that PRP is going to help you out and achieve your goals. So I kind of explained it like, hey, you can't guarantee any treatment is going to work. Just know from the data and your clinical experience what is most likely to help the patient without being the least invasive of that type of treatment.
Absolutely. Absolutely. Well, we have one final question for you, John. And so the question is, should there be a global consensus or registry for using culture expanded stem cells? Or, if we're like, how do we self-police and say, okay, Dr. Solar in Spain is doing this, and Cayman is doing that, and Bahamas is doing this, and San Diego's doing that. Not those registries, like, should we as a group of physicians who are out in front in the cutting edge be in charge of also policing ourselves? Or what are your thoughts on, how do we do this in a responsible fashion? Because I believe that culture expanded is going to be the next step. And how do we avoid this Wild West experience and be methodical and thoughtful about this? And should we be in charge of policing ourselves?
Yeah, I mean, we have to, at this point, kind of police ourselves because there's no kind of regulatory agency is going to do a global policing. So, one of the big things for me is that people ask me about out the country treatments. I can only vouch for what I do and what I've seen. I can't vouch for any other clinic because I don't know their protocols. I don't know how well trained their physicians are, et cetera. Unless it's, a U.S. physician that's, maybe going overseas like us as well. But I think the onus is on each individual clinic to at least track their particular protocols and outcomes, because not everybody's doing the same thing. If you're doing autologous bone marrow culture cells with a specific protocol, you need to track that data. You need to publish research. You need to put in, what's your cell dose that you're using? Are you growing those normal cytic or hypoxic? How much volume are you using, et cetera? So you want to get as much details and publish as much research and at least do some registry tracking and data and publish that, to kind of, see what helps and what doses help. Because we don't really have any great dosing guidelines for a lot of culture expanded cellular treatments as we do for like PRP, which is still lacking quite a bit as well. But we got more dosing guidelines for PRP than culture cells right now. And so, we have to publish some data. And so the problem is that, hey, if you're in another country and you're just running a clinic or a private practice, again, you just want to do your job. Hey, I just want to treat patients, even if you're altruistic and you're not, doing sham stuff, you might not be interested in doing research. But when you're pioneering the field, you kind of have that inherent responsibility to say, hey, I see this work, and you have to prove what you're doing is having a positive effect, and how can things be improved if you're really serious about getting patients better. So obviously we track our patients, we publish data. It's great. We have a full-time doctor now down there that can help publish some more peer-reviewed literature. So I think all that's going to be helpful. But then, we can talk and collaborate when possible to kind of share some ideas so we can keep learning from each other as well.
Yeah, absolutely. Absolutely. Well, John, thank you so much. Is there anything else that you think that physicians who are looking towards and maybe helping to inform their patients about what those options are out there, what they should be looking for? Because you're right. I get questions all the time about, oh, hey, what about Panama? What about Mexico? Why should, I'm like, I've tried to do the research and I don't know. Maybe I'll invite him on my show and we'll get down to business.
Yeah, I'd be very curious about some of these popular clinics like in Panama, Colombia. And if we're doing this a little while and, maybe have some reputation to say, hey, are you tracking any data? Are you having any publications? Are you having, what's working, what's not? That'd be very helpful. And, a lot of those clinics are doing different things. They're doing culture expanded allogeneic cells, mostly from birth tissues, which I think, for me, I feel right now, I already know culture stem cells work. This is what I do on myself. So anytime I'm down in Cayman treating folks, and there's another doctor there, I'm getting something that I have a problem treated. So I believe in it. I do it myself. I use this for my problems. So I know these things work, but I still got to prove that it works to other folks. I know that our lab is, CMGP certified. So I want to know, do these other clinics have clean lab room? Are they following good, current good manufacturing practices? Are they having any risk of infection? Are they checking for, bacterial infections? Are they doing cell viability counts when they bring the cells out of cryo storage? Because if you look at some of the allogeneic data from birth tissues, some of their viability rates are like 50, 60%, where they should be in, upper 80s, 90%. So these are the things we have to tease out. And if you're doing allogeneic cells, are you doing any things to kind of mitigate potential risk for allergic reaction or graft versus host, or even if they don't have those major immune responses, are they at least accounting for, hey, the cells might get taken out eventually, so you might have shorter duration of effects? Or are you using different pool of cells, because once you get used to one pool of cells, your body can then start to develop markers to attack those cells, which have been shown in some of the research as well. So I've got so many research questions and biologic questions about some of these other places. I would love to know that and
Right.
publish data.
Let's see if we can get them on here and get some real raw conversation. Well, I wanted to thank you so much for your time and your expertise and your knowledge. You've been at this a bit and you've got a lot of expertise that, thank you so much for sharing this experience with all of us. And I appreciate your time. So
thank you for having me anytime.
Absolutely. What I wanted to share with you guys is the next step is attracting the right patients, right? We've gotten the orthobiologic knowledge from the illustrious John Pitts, and now we need to figure out how the heck to use all this knowledge for the right patients, for the ones that need your help. I've created this webinar. It's the Regen Patient Magnet Method, like how to get results and grow your practice, how to attract those perfect regenerative medicine patients for those who need your services. And you can scan the QR code. It is a full hour of really high dollar workshop style, get it done today. And that's on the May 31st, Saturday, 8 a.m. Pacific, 11 a.m. Eastern. There is a $47 registration fee, but please come on down. If you want the fast track, we are having Bob Live at Toby. And so come, if you're going to be at Toby, come a day early, come to Bob Live. It's the whole framework for orthobiologic practice launch system in one day. So let's do this. This is awesome. This is going to help you figure out how to integrate your workflow with PRP, get a step-by-step roadmap, and obviously proven strategies. So definitely not a day to miss. Get it all done in one day. Our registration opens June 1st. So we will only have 10 spots for the VIP. Regularly, it's $8.95 for the entire day. Proven strategies, the 30, 60, and 90-day roadmap, patient-centered branding workshop, actionable pricing models, and how best to have success. So if you're interested, just reserve your spot. $50 reserves your spot for the price of 40% off, which is $537. So if you want to save a little bit of money, reserve your price now. And then when registration opens up June 1st, you'll get that early access to complete that sign up at the special rate before the price goes up. So if that's something you want to do, come join me that Thursday before Toby and really do a deep dive on the seamless integration of orthobiologics. So I wanted to thank you so much, and then we're going to open it up for questions. So Brad, you look like you got this all alone, so this is a you and me time. Put your video on and let's chat and let's get you some super duper value. Hopefully you got a lot out of this, and let's see what you know.
So thanks for putting that together on that last lecture that you had in terms of, it's always interesting to have different people and their different perspectives in terms of what works, what doesn't work. And
Yeah.
and it was interesting when he was talking about the volume, because you were a big proponent of that. For PRP, you need to have the billion cells.
10 billion.
Um,
Yes, 10 billion
10
dose.
billion.
Yep. So that was he was alluding to the fact that we do have some dosing for PRP. What we don't have is that dose response curve for culture expanded cells. We just don't have enough volume. And my guess is Regenix, I know they have a registry that they're following all their patients and have for a long time. And so I think they're starting to get dosing data for what works, what doesn't. And I know Dr. Solar in Barcelona has some dosing data for Achilles tendon, partial tendon tears with culture expanded cells. But, this is a worldwide network of physicians and clinics that are doing this at a very high level. And so these are all things that I have questions about, should I be sending my patients down to Cayman, down to Bahamas? Should I be doing like really aggressively pursuing the FDA trials here in the States? So, John Pitts has been doing this a while. He's, 10 years into this. He has 10 years of experience with culture expanded bone marrow concentrate, autogenous bone marrow concentrate cells. And so, I try to call on the experts and say, hey, how do we think about this for those of us who don't have access to this? And is this the next step forward? Are all of us going to be wanting bedside GMP facility kind of labs, or how are we going to do this?
Can I ask you that? But when we talked about the number of cells that you need, either culture expanded or PRP, and he brought up about the consideration for a small joint because you don't have much volume.
Yeah.
What has been your experience with using PRP for small joints or for areas that you're limited in the amount, the volume that you put in there? Have you had any experience or thoughts about that?
Yeah, absolutely. So I think that the best data is probably in the thumb CMC joint, and it's a small joint. You can hold maybe, zero point 0.7 cc's to maybe 1 cc max. And so what you're looking at is even if you are able to get somewhere in the 2 billion range, it's still not 10 billion. And does it matter because of the surface area? Like, I don't think we have that data yet. We don't have those studies done to show that dose response curve for CMC arthritis. What we do know is there's some data that supports not only an intra-articular injection, but ligamentous injection as well to stabilize the joint. And it's approximately 40% incidence of low-level carpal tunnel syndrome with CMC arthritis. And so is it causative? Is, that low-level carpal tunnel causative of CMC, or does CMC arthritis with the contraction of the carpal tunnel cause more increase? I don't think we have causative data yet, but we do have correlative data where we see these things together, and when we see them together and we treat them both, we have better results. So when I'm treating CMC arthritis, I'm treating both intra-articular, ligamentous, and carpal tunnel.
Okay.
Yeah. So I think that's a great question, and that was such a good indication for culture expanded, because then that you dial in your dose, and that's it. That is cellular dose, that is not platelet dose. And so when you're looking at cell counts for PRP, we're talking about platelet count. When we're talking about cell count for BMC in the point of care reference, you can do a TNCC count, and that's what he's referencing, is above 400 million TNCC for knee arthritis shows better outcomes than a TNCC count below 400 million. And so we start to just try to plot these known data points and then try to at least meet those. Now, if you're doing bone marrow concentrate and you don't, that 400 million is intra-articular only. So if you are not able to get the even 400 million TNCC with an intra-articular only, then you're going to be caught short and you're not going to have enough BMC to then do intraosseous as well. So you start to have to do the math about how do you get that information. Now, if you look at Carnegie's data, there is a comparison intra-articular BMC versus intraosseous BMC from a longevity standpoint, like how long do these outcomes last? And what it appears is that intra-articular BMC has about a 3.5 to 4 year lifespan of symptom relief, whereas intraosseous has a significantly longer symptom relief profile with that 15-year data point where 85% still had relief after intraosseous BMC high volume 150 cc draw. So we don't have all the answers yet. And so, collecting your data, everybody really needs to be collecting data, and everybody needs to be recording their cellular content as best of their knowledge. Everybody needs to be having, validated patient-reported outcomes and doing the best we can to be very precise about recording protocols of exactly where you injected, what you injected, when you injected, how you injected, what dose, what volume, and just being really scientific about this. So that's, I think, where we have fallen down. And he kind of alluded to the fact that as a private practice, like, how do you have time to do this? How do you have the resources to do this? And I would say, the onus is on us, and I do this for my patients because now I know what my patients can expect from me, right? And so if I know what my patients can expect from me and I can tell them, hey, this is my protocol, this is my data, this is what I do, then they know that it's not just some, pie in the sky research. It's actually my data with my protocols and my technique.
Yeah, yeah. And not to keep you long, do you know if they have done a study with just the PRP intraosseous for a knee as opposed to, and comparing that with bone marrow? Because I know some time ago there's the instance of avascular necrosis of the hip. It was like, 80% go on to have a bad outcome. And then they were doing some core decompression with, I thought they actually did PRP into it, but maybe it was
Yeah,
all bone marrow,
I
and
think
there
it
was
was bone
80%
marrow.
resolution of symptoms.
Yeah, that's Hernig's data as well.
Hmm.
Yeah, he's been prolific, that guy. And he non-collapsed AVN when core decompression with bone marrow concentrate injection had actually a really good outcome. And so ultimately, yeah, like absolutely when we talk about AVN, when we talk about arthritis, because then he redid that study, intraosseous BMC for hip arthritis, which is not the same as AVN. Even though we have the same endpoint, which is total hip, it is not the same root cause, right? And so this is a different animal. Arthritis versus AVN is a very different animal. But
So
yeah,
he did not get the same results with the hip as he did it in the knee
he got very similar results with intraosseous.
at the hip. Okay.
Yeah. Now, those patients were not as severe as the patients with the knee arthritis, but still quite compelling. Yeah, I think that this is not a solved problem yet. This is a very exciting field, and it changes, yearly, monthly, weekly, daily. There's just an explosion of research and knowledge that is continuing to expand and inform the ways that we treat our patients. And, in part, it is hard to stay abreast of what's new, what's coming out, what the latest, greatest data is, because I think there's a bit of a bias for the mainstream journals to be known for or publishing the regenerative therapy literature. There is the Journal of Biologic Orthopedics, which is definitely leading the way for these publications, but that's just one journal. And so ultimately, that is where we're at.
Well, thank you so much.